officers um, can support their clients who are actively engaged in treatment. Your guys' role is super powerful in this. I do realize that your primary responsibility is supervision and public safety, but you're also in a unique position to help motivate change in a way that treatment providers can't. A lot of your clients are going to see you more consistently than they see their own families. And the tone that you set for them can either encourage engagement in treatment or create some resistance. So, what we're going to do is we're going to look at some practical and realistic steps, things that you can start using today to help reinforce treatment goals, communicate effectively with clinicians, and then navigate confidentiality rules without overstepping those professional boundaries. I'll actually go over what the confidentiality rules are that like providers like myself are bound to. We'll talk about examples, some language to avoid, and then common pitfalls. Hopefully, at the end, if I've done my job, you'll feel more confident in partnering with treatment providers, supporting your client's progress, and holding individuals accountable to their own recovery plans. So, why this matters? It's a great question. I'm going to tell you. Integrated supervision and treatment reduces recidivism. So if we look at this, the overlap between probation supervision and treatment isn't accidental, it's actually essential. So research consistently shows that people who receive structured supervision and appropriate behavioral health treatment are less likely to reoffend than those who just receive one or the other. If you consider the fact that half of the individuals on probation have a diagnosable substance use disorder or a significant mental health challenge, a lot of them are also struggling with their trauma history, with unstable living environments. Treatment can help address the root causes of that criminal behavior, including substance misuse, impulsivity, untreated trauma, while probation provides that external structure and accountability that we can't give. You might feel like your job, sometimes you feel like treatment side is not your job, but your influence is actually like super huge in this. The way that you talk to clients about counseling, the flexibility that you show in scheduling, and the respect that you give to those therapeutic boundaries can make all the difference between somebody sticking with treatment or dropping out. And when probation officers and treatment providers present a united front, clients have the clear message that everyone is on the same team, supporting them and supporting their change while also keeping the community safe. Let's talk about some treatment basics, right? I'm going to guess a lot of you have heard of the stages of change, but we'll talk about it briefly as well. So in order to support clients effectively, it helps for you guys to understand what like treatment actually entails. So clients might be in individual therapy, group counseling, intensive outpatient programs, or medication-assisted treatment. So that has been known as MAT. It is also known now as medication for opioid use disorder, or MOUD. That's things like Suboxone or methadone. Goals of treatment generally include stabilization, skill building, coping strategies, relapse prevention plans, and ultimately long-term lifestyle change, right? Like most people don't wake up one morning and think, I'm going to start using meth. There's a series of events that led them there, and treatment can help address that underlying cause that brought them to those thinking errors in the first place. So the stage of change model, where we look at pre-contemplation, contemplation, preparation, action, and maintenance, it talks about this upward spiral. And when you see the stages of change model, you're going to often see it as this like circle or this like line that leads to one another. The thing to remember this is that it is like somebody could go from pre-contemplative to preparation to then relapse to contemplation. Like it's not necessarily a smooth line. They kind of go through this spiral, and each time there might be a lapse or a relapse, they do learn from it. So someone might be in action for attending therapy, but pre-contemplative about stopping alcohol use. Like, hey, I'm super like gung-ho about getting counseling, but I still don't really think I have a problem or want to stop drinking. Like they can be in two different stages at the same time, depending on like what's going on. So the probation officers, your guys' interactions can either help move them forward or push them back. Small acknowledgments and validation, like I can tell you really made an effort to get to that group in spite of your work schedule, reinforces those positive steps, right? Just acknowledging that a lot of times this is really difficult for them to do. Like, I see you're trying really hard. Conversely, that confrontational or dismissive comments can often trigger resistance, right? Like, I don't know about you guys, but if someone starts calling me out for stuff, even if they're right, my hackles are going to go up and I'm going to dig in and I'm going to get real defensive because I'm probably not ready to address that yet. So if we just switch the verbiage and the tone, it can work towards having change instead of that like resistance and digging in. Also, please remember that setbacks are normal. It happens. Relapses or lapses can be, or missed groups. It doesn't mean that treatment's failed or that the client has failed. There are going to be opportunities to revisit coping strategies and strengthen motivation, right? So anytime someone reports a lapse or a relapse, I always tell them you have 3 business days to tell your probation officer, and then I'm going to tell them. And I say 3 business days because I'm not in the office on Fridays. But I tell them that, and then I'm like, this is your opportunity to talk to your PO about it before I do, and I'm going to follow up either way. That conversation with the client is also going to involve what were you thinking and feeling leading up to the lapse? Like, let's talk about it. Let's see where we can make some changes. And a lot of that is going to be included in my email follow up to their external source to let them know what we're working on and that we are making progress. And then if there was any kind of treatment response, like additional groups or additional meetings. Excuse me. When clients say they're going to treatment, it can feel like a little bit of a black box for you guys if you've never actually been in a therapy session yourself, which I highly recommend everybody go to therapy. I have a therapist. I think it's great, not just because I am a therapist. So if we understand the common clinical approaches, it's going to give us insight into what your clients are actually working on, and it helps you talk with them in a more informed and supportive way. So we have CBT, which is cognitive behavioral therapy. It's actually one of the most widely used evidence-based methods, and it focuses on the connection between our thoughts, feelings, and behaviors. Clients are going to learn ways to identify like automatic or distorted thoughts, like I always fail, I'm worthless. If I get angry, I have to replace those thoughts. Or if I get angry, I have to use to calm down. And then it's going to give them a little more challenge and help them replace those thoughts with balanced ones. So the idea is that changing the thought pattern leads to healthier emotions and better choices, right? So a lot of times we have a thought and then it leads to an emotion and then it has a behavior. Or we have an emotion that leads to a thought that leads to a behavior, right? They kind of all go together. And so if we can identify just one piece of that to change, it changes the whole cycle. So when you hear a client say, I've started catching myself when I am engaging in negative self-talk, that is directly a CBT skill in action. Most substance use treatment is based in CBT. And then we have DBT. So it's another common model, especially for people who struggle with emotional dysregulation or high-risk behaviors. This was actually developed for those with personality disorders. However, the way that I like to explain DBT is it's like how to be a person skills, like how to be an effective adult. DBT is what's known as a third wave DBT or CBT. You might hear your clients call it diabolical behavioral therapy. A lot of them can't remember dialectical, and so they just roll with diabolical, which I also think is hilarious running DBT groups. So it combines CBT principles and then adds mindfulness and acceptance strategies. So there's 4 key areas. So there's emotion regulation, which is obviously understanding and naming emotions before they escalate. I always tell clients there's more emotions than happy, sad, mad. Those are kind of like the umbrella. And then there's like the 31 flavors of emotion underneath, because irritation and wrath, although they're both anger feelings, are very different from one another. We'll talk about distress tolerance, and that is how to survive a crisis without making things worse. A lot of our clients are really good at making things worse. They might see, like a small fire and they're like, what would happen if I pour gasoline on it? Let's find out. That sounds fun. And then it explodes and they're like, I don't know what happened. So it's going to address like how to back down from that crisis so we don't like mess things up worse for ourselves. We've got interpersonal effectiveness skills, which is looking at assertive and respectful communication. So it's really like how to say no to unwanted requests, how to set boundaries, how to get yourself to be taken seriously, using these different skills with individuals. And then mindfulness, which is staying present rather than being swept away by our thoughts or urges. A lot of our clients end up living in the past or future tripping about stuff that hasn't happened yet. And so this is going to look at just keeping them grounded in one area. There's also one activity that's done in DBT that I really love. It's called a chain analysis. And it is kind of similar to like the behavior analysis that is in Sabisa. But what they look at is I've got this problem behavior, and then I had a trigger, and then they have to go through and list every thought, feeling, and action that happened in between the trigger to the problem behavior to see where they could have done a different type of skill or use something more effectively to stop the rest of the chain from happening. So it's really looking at how can I change these behaviors so they don't continue to happen. You might also hear about motivational interviewing. This is huge in substance use treatment. It's going to help people resolve that ambivalence to change. There's also trauma-focused therapies like EMDR or trauma-focused CBT. EMDR is going to be helpful for processing the negative core beliefs that come from previous trauma and rewriting neural pathways. And then there's also structured relapse prevention planning for substance use, which again looks at triggers. It helps them come up with a plan for supports and what they're going to do when they're triggered. For you guys, this knowledge is super valuable because it's going to help you be able to set realistic expectations for people. So if a client says, I'm working on coping skills or I'm working on challenging my thinking, then you understand that this is a specific and measurable treatment goal. You can help reinforce their efforts with simple check-ins like how is their thought log going, or what DBT skills have they been using this last week, without stepping into the therapist role. Like you can just check in and be like, what'd you learn this week? And then recognizing that these approaches build credibility and trust when you talk with the other treatment providers because you're speaking their language and understanding the purpose behind the work that they're doing with clients and the work that you're doing. Any questions so far? Nobody's shouted at me, so we're doing okay? Okay. So the ASAM dimensions. This one is a little bit of an interesting sticky wicket right now because iDoc has adopted the ASAM 4th edition, which came out earlier last year. However, Medicaid and Magellan will not be adopting the 4th edition until January of 2027 because the adolescent version isn't out yet. So they're super similar, but because Medicaid ends up funding quite a lot of clients, I thought that I would just stick with the 3rd edition. It doesn't change too much. It kind of mushes a couple of the dimensions, so this will still serve its purpose. So when a client enters substance use treatment, ASAM criteria is like required for us to assess. That's how we're going to determine level of care. It was developed in the 80s. They had like all of these providers. I think there was like 50 different people that got together because they're like, we have to come up with something that is going to guide this. Insurance companies require different things. Like nobody was on the same page. So they're like, let's get together and put this together. So it was developed by the American Society of Addiction Medicine to guide that level of care decision. It's this whole person evaluation that covers 6 dimensions. So if you guys are looking at assessments, a lot of times these dimensions are going to be towards the end of it. So the dimension 1 is acute intoxication or withdrawal potential. So this is looking at, is the client currently intoxicated? Are they at medical risk for withdrawal for something that might need medication management? It's also going to include like what's their drug of choice, what's their method of choice, if they've been incarcerated anytime recently, and we'll talk about that, why that matters when we get to dimension 5. because that can put them at increased risk depending on what their drug of choice is and how long they've been outside of a controlled environment. Dimension two is looking at that physical body. So, are there physical health issues, diabetes, chronic pain that could impact treatment? Do they have health insurance? When was their last physical? Do they have a dentist? All of these different things that are going to affect the physical body. Dimension three looks at mental health. So things like depression, trauma, any cognitive impairment that needs to be addressed, any thinking errors, any issues with impulse control. Um, do they seem to have an idea of how their substance use might be exacerbating their mental health? Are they using it to cope with it? Are they using it to cope with underlying trauma? Dimension four is that readiness to change. We talked about that just a little minute ago. So, how motivated is the client to engage in treatment right now? One of the questions, like the way that I assess this is I'm like, on a scale of 0 to 100, how ready are you to stay sober? And if they say 70, I use that little bit of motivational interviewing and I'm like, why not 60? And if they like, they'll tell me whatever. And then I'm like, what would get you to 80? And then I look at what is their like most important reason to have sobriety to see if it's I don't want to go back to jail, which is externally motivated, my family, my friends, my kids, which are all externally motivated. If they say I want a different life, that's internal motivation. And so I'm going to put all that together to see what their risk level is in that dimension as well. Dimension five is relapse or continued use potential. So this is looking at what's the likelihood of returning to use or the problems that create risk. You will see dimensions one and three are going to be pulled through dimension five. One of the biggest things about why we ask what their substance of choice is and when they were last incarcerated is the physical dependence, specifically with opiates. I don't know if you guys have lost people, but within the last couple years, like 2, 3 years, I have lost more people than in my entire career to overdoses. And what has happened is when somebody is incarcerated in a controlled environment and then they come out, that physical body tolerance is gone. And so a lot of times people will go back to using the same amount that they used prior to it and they'll overdose. We also have things like fentanyl now, which I don't know if you guys know this, but the people that deal or make drugs are not pharmacologists. And so they have no idea what they're doing when they're pressing pills in their home. And there is also xylazine. And I don't know if you guys have heard about xylazine. Sandy and I were just talking about this, doing some trainings for some other court districts. Xylazine is also known as tranq or the zombie drug. Xylazine is not made for human consumption, period. It is a large animal tranquilizer. So horses and cattle. And what's happening is it's being added into substances because it gives it legs. And so the high from fentanyl, depending on how they use, is very short. And if it is mixed with something like xylazine, it makes the high last longer. The problem with it is because it's not an opiate, it is irreversible by Narcan. And so even if you're using Narcan on somebody that did take an opiate, it's knocking that the opioid off the mu receptor in their brain. However, the xylazine, which is still a depressant, is affecting their system and they may still overdose. So I want you guys to be aware of the risk level with this. And then it is also something that we very much take into account. We send clients out with Narcan, the Never Use Alone hotline, and I do a lot of education of, hey, drugs have really changed since you've been incarcerated. You can't go back to using the same way. And fentanyl is in everything. I've had people that use marijuana that have come up positive for it. I've had people that use methamphetamine that has come up positive for it. And they have no idea. And so they might be like, I don't use opiates, I'm fine. And then they still overdose because it was in their other drugs. It's really going to look at the likelihood of having problems in this dimension. Scary out there. And then we have dimension six, which is recovery and living environment. So this is looking at, does the individual have stable housing, supportive relationships? And I always check with people to see, are they sober supports? Because the people you use with aren't your friends, they're people you use with. So do you have sober support system? available for you? Are there triggers? Are there unsafe conditions? Do you have a job? Are you on probation? For you guys, I don't expect you to have to memorize all of these details, right? Like it's a lot. Like I took an entire class on it in grad school. But for you guys, just knowing that clinicians are evaluating all of these factors helps you understand where the treatment recommendation is going to come from. Or when you look at it and you're like, oh, that's a mild risk in that dimension, like what does that mean? You'll have a better understanding when reading through assessments. So, for example, a provider might recommend residential care not just because of drug use, but because the recovery environment is unsafe or there's medical issues that also need to be addressed. Again, it's going to help drive treatment planning and then help you interpret updates. And then we have the level of care. So this one, it's I'm faculty over at BSU and I actually teach assessment and diagnosis. And when I get to this section, I'm like, you just feel it. And they always hate that answer because they're like, how do I know which level of care? And I'm like, you just do. There's like a crosswalk and a matrix and everything for it, but you also just like your clinical judgment, it just kind of tells you where they're going to be successful. So this is going to take those 6 dimensions and ensure that the treatment intensity matches their needs. So point 5 is early intervention. So this is people who don't meet criteria for like substance use disorder but need education or brief counseling. This is like drug and alcohol education. Level 1 is outpatient. So this is going to be 8 or less group hours a week. It's going to be people maybe with stable living conditions, not a ton going on, but they could use some education. We have level 2. So 2.1 is intensive outpatient. So this is going to be like 9 to 20 hours of individual of groups. There's also going to be individual counseling, case management, recovery coaching, all of that sort of stuff. And then we have 2.5, which is partial hospitalization. So partial hospitalization is usually about 30 hours. Like it is an all-day program, 5 days a week. Really, really intensive. Some have, it's going to be when clients need like a lot more support. It's usually about 4 weeks, and then people would step down from there into intensive outpatient. There's residential slash inpatient. So this is a 24-hour live-in treatment, which provides structured environment and medical and clinical services. There are some places that might say that they are residential. However, they're really just PHP with housing. So it's important to understand the difference there. Sandy, I saw you come off mute. Do you have something for me?
I was just going to ask you, and I should know the answer to this, and maybe other people do, but with IOP and partial, weren't some of those eliminated by Medicaid, or was that just for mental health?
So they still exist through Medicaid. What Medicaid has done is like cut a lot of the units for it. So now somebody is only eligible for 50 units of intensive outpatient, and it's a unit per day. And so you might see that some people have had to step down a lower level of care, maybe prior to them being like fully ready, and it's just because their coverage ran out. And so you work within the system as best we can. They did, however, just so you guys are aware, it's actually a really good point. Thank you for reminding me about that, Sandy, is they, as of the end of February, safe and sober housing funding for those over the age of 24 has been cut. So I don't know about you guys. I know I have a lot of people that we're trying to navigate with that, but it's no longer going to cover safe and sober housing. And a lot of places had stopped taking funding to begin with. And so a lot of the rent is, between $500 and $750 a month. And, our clients just getting out that maybe don't have jobs yet, that's going to be really difficult. And so I think we're going to see an influx of people having to go to the shelters. Thank you for reminding me of that, Sandy. And then level 4, there's different levels. This is going to be medically managed inpatient treatment. So this is going to be like hospital level for severe withdrawal, complex medical needs, high psychiatric risk. Clients can step up or down depending on their progress. So someone might start at residential to stabilize and then transition into level two and then transition into outpatient while they gain those supports. So if you hear someone recommend 2.1 or 3.5, it's a subcategory indicating like slightly different intensity levels. So there's 3.1, 3.5, 3.7. It's all the same like meat and potatoes. It's just like the number of services that are available in that level. For you guys, again, knowing these broad categories is going to help you to understand the significance of provider recommendations and why a client might change programs during supervision. And I know, like, we collaborate on that. We will let you guys know, like, hey, they've got to increase level of care. A lot of times, if somebody pushes back and they're not doing that, I am going to end up having to discharge you for that higher level of care and give you referrals. And that's where I hope that, like, the probation officers with that external motivation that you guys have that we don't can be like, you might not like the alternative, which is a PV and going into custody. So maybe you just like step up that level of care and let's try something different. Confidentiality. So this is actually the backbone of effective therapy and it's governed by federal law. So HIPAA, as we're all aware of what HIPAA is, it actually protects that mental health information. And then 42 CFR Part 2 is additional safeguards for substance use treatment records. So substance use treatment is actually bound more to confidentiality than just plain mental health treatment. And so the key point, obviously, without a signed release of information, we cannot share anything beyond the bare minimum needed for emergencies or like collaboration of care. Even at like the most basic level, most providers will share attendance, engagement level, or whether the requirements are being met, not the content of the sessions, right? So I'm going to let you guys know they're actively engaging. They often share personal examples with the group, give feedback to their other members. Their UAs have been negative and they're attending consistently. I won't talk about what is going on in the individual session just because that's not part of the bare minimum or what would be covered under this, and it would break down that therapeutic alliance. So it's the minimum necessary disclosure. Again, it's not to frustrate you guys, it's to like keep them coming, and the fact that clients do need a private space to be able to be honest about their struggles. So for you guys, when you request information, be precise. Ask for confirmation of attendance, compliance with court-ordered treatment. If you are noticing things that you think we should know, if we haven't gotten access to drug testing or it's pending or they reported a relapse to you, like that's valuable information for us as well. So the collaboration goes both ways for us. We're going to get a written release from the client first, or you might get an email from me if you've asked questions and you and I respond with, do you happen to have an ROI for this individual? And that is because either they didn't tell us they were on probation, they got on probation afterwards, or we don't have a release. That is my saying without saying, please send me over your release so we can talk. Um, Clarify what information is going to be shared and for how long. They do have like the little expiration dates. I think for you guys, it's usually the end of their probationary period. For us, it usually says end of treatment. And then having that understanding and respect for boundaries on both sides will help build that trust between all parties. Communication do's and don'ts. When you do communicate with providers, where you keep it professional, factual, collaborative, please do share information, attendance verification, missed appointments, new court dates. That's always beneficial for us. Sometimes there's a little bit of a delay with my courts. Ask for how you could best support the treatment goals. For example, of like aligning reporting schedules. And then use that neutral language that frames as a partner, not the enforcer. Don't please request detailed therapy notes or ask what was said in session. Detailed therapy notes, those actually have to have a signed judge's order, like a subpoena is not enough just because of 42 CFR Part 2. We don't want to offer clinical opinions or diagnosis or about treatment methods, like that's the clinician's role. We don't want to speak about a client in a way that undermines the trust in the therapeutic process. So there, you could do like an email of like, hey, I'd like to confirm Bob. Bob's always got issues. Whenever I use Bob, he's always got these like problems going on in his life. So I'd like to confirm Bob's attendance and see if there's anything that you need from me to help him stay engaged. So this communicates support and respect for all parties. And the approach encourages providers to look at you as a teammate as well. Like we really value your guys' input and your support, reaching out like, hey, we're doing an assessment. Do you have any collateral information? Because again, if somebody's just brand new coming into my office, I don't know anything about them. And sometimes, I don't know if you guys know this, if you've experienced it, sometimes clients are poor historians and maybe don't share all of the information that we need for everything. And so you guys might have that, especially like drug testing results, because we won't have that yet. So just having that partnership again is going to be beneficial for everybody. To support treatment goals, it's pretty simple, and it's super powerful though. So coordinate flexibility so it doesn't conflict with therapy times. It shows again that you're valuing their engagement in treatment and supporting their process. Acknowledge their effort, right? So a quick comment of like, I know it's not easy juggling work and treatment and all of your obligations, and you're making it happen. It's going to go a long way towards motivation. It's also going to go a really long way with rapport building. They're going to be more likely to want to talk to you guys about stuff if you're acknowledging that they're trying. Integrate therapy homework into your check-in. So open-ended questions like how did coping skills practice go this week? Like we talked about, did you learn any new skills? Um, just showing the interest signals that you and the therapist are on the same team. I kind of look at this like when your kid gets home from school and you're like, what'd you learn today? They might say stuff. That's okay. You still showed an interest, or how was your day? Fine. I remember my mom's like, well, what'd you learn? Like math. Well, what about math? I don't know. It was math. Like I don't want to talk about it, but I at least knew that she cared or that she was checking in to see how my day was going. And then finally, celebrate those milestones. Completing an intensive outpatient program. IOP is like 3 to 6 months. It's a lot, and it's 9 to 12 hours a group a week. Like it, and individual therapy, it's a lot. Or maintaining those sobriety milestones, like 30, 60, 90 days, all of those, they deserve recognition, and having that positive reinforcement from their probation officer can be a powerful motivator, and again demonstrates that the accountability that you guys hold them to and the encouragement coexists. One of the things you can ask is if they are going to meetings, like if that's their jam, if they got a chip, you can offer to give it juju, which is where they will give you your chip and you kind of just like hold it and put positive intention on it for them. I always let people, if they have one, they can pass it around the group. I ask like, hey, do you want like your group members juju? And they pass it around, and then they are always pretty excited by having that intention. Removing barriers. So, a lot of clients face real world obstacles that make treatment attendance difficult. Transportation problems, the bus route in Boise. I don't know about everywhere else, but the bus route in Boise is rough. I think Caldwell is too. Like, it stops running at like 5, it doesn't go everywhere. I do realize that clients have Lamborghinis and Chevrolets, but that is rough sometimes getting around. It's getting cold out. Subarus, if you will. Gaps in childcare or unpredictable work schedules. These are all going to be barriers that they're dealing with. So if we're looking at having that supportive role, it's going to be helping to identify and reduce those barriers. We can ask questions like, is transportation ever an issue with you getting to treatment? And then connect them with resources like bus passes, rideshare vouchers, local volunteer drivers programs. If they have Medicaid, you can remind them that MTM transportation is a part of Medicaid, and they will pick them up and bring them to treatment and then take them home. If childcare is an issue, you can collaborate with the providers to explore family-friendly scheduling or remote sessions, right? Like everything that Trivium does is hybrid. So telehealth is available for everything that we offer. And I specifically like have a sign out in our lobby of, are you sick? Did your car break down? Did your babysitter cancel? Call and ask for a Zoom link, because then they're not missing their groups. And it's just removing one more barrier to care. If an employment conflict arises, you could adjust reporting requirements to accommodate therapy appointments, as long as public safety isn't compromised, right? We want to keep that in our minds the whole time. And again, these efforts are going to send that strong message that you're invested in a client success and not just compliance. People who feel understood and supported, again, are more likely to stay in treatment and actually avoid violations. Motivational interviewing, I touched on this just briefly a little bit ago. So, motivational interviewing, or MI, is actually a client-centered communication style that fits perfectly with probation. The goal is to elicit the client's own reasons for change rather than imposing our agenda. So, core techniques are open-ended questions, affirmations, reflective listening, and summaries, referred to as ORs. Yes, Sandy.
I was just gonna say, and somebody can correct me if I'm wrong, but I think they teach motivational interviewing at Post still.
Ooh, I do love
True?
that.
Carrie Anderson? True? Justin Collins is saying yes? Okay,
Got some nods.
good.
Fantastic. I love that. Okay, so you guys all know about this. So quick refresher then. You can say, like, for example, what do you see as benefits for staying in treatment? Or it sounds like attending counseling is really helping you manage that stress. So when clients hear their motivations reflected back, resistance decreases. So instead of saying you need to stop drinking, you can say you've mentioned wanting to keep your job and stay out of jail. Does drinking actually align with those goals that you have? Even those just brief MI conversations can help enhance that treatment engagement and help them move through those stages of change. Trauma-informed supervision. I'm going to assume that you guys get training on this too, or attend trainings on your own on this part. So a large percentage of those that are involved in the justice system have experienced trauma. Whether it be childhood abuse, domestic violence, community violence, trauma can manifest as irritability, mistrust, difficulty regulating emotions. A trauma-informed approach recognizes that these behaviors often stem from survival strategies, not defiance. So we can look at things like offering a calm, predictable tone, offering choices whenever possible to give clients a sense of control. They might not like the choice options, but they can still make a choice. Avoid unnecessary threats or surprises, and then recognize triggers like loud voices or sudden changes in their routine. Again, this isn't like excusing harmful or illegal behavior or lowering our standards. It's creating the environment where clients would feel safe enough to engage or tell us what's going on, which again then turns into treatment and turns their support to treatment and more compliance. Effective coordination with treatment providers requires clarity and consistency from the start. So identify a primary point of contact. It's likely going to be their probation or their individual therapist. I know that Ada County misdemeanor probation, a lot of times it's me because I respond far too quickly sometimes, I think, to my emails because I just see them and it gives me anxiety to have unanswered emails. So I respond pretty quickly and then I include whoever it needs to go to as well. A monthly or biweekly check-in catches small issues like we do monthly reporting. Respect confidentiality by using secure communication methods like encrypted emails, scheduled phone calls, portals. Always verify that the release is in place before sharing or requesting details. Treatment providers are going to do that as well. And then frame every interaction as a shared effort to help the client succeed and help keep the community safe. When providers see that you respect clinical boundaries and clearly communicate your goals, that partnership just increases. When problems arise, setbacks, missed sessions, relapse, catching new charges, it is part of the change process. It's a frustrating part of the change process, but part of it nonetheless. So your first step is to gather accurate information from both the client and the provider. We want to avoid snap judgments. Use a graduated response, sometimes an extra check-in, a written warning, combined with treatment adjustments is a lot of times more effective than an immediate violation. And then engage the provider into problem solving. Like, what do you recommend? Or this is what I've noticed. Like, what can we do to collaborate to like address these problems? That united front is also going to show the client that accountability and support work together, not opposing each other. It also helps reduce the triangulation where they're telling us one thing and telling you guys another. Cultural and individual sensitivity. So every client is going to bring a unique cultural, racial, gender, and personal experience. Cultural humility means approaching each of those interactions with curiosity rather than an assumption. Ask a client's preferred name. Like, do you prefer Joshua or Josh? Um, Zachary or Zach? Like, I always check and see. Ask them what their pronouns are and use that language when possible. You can also ask open-ended questions of are there any cultural or family considerations that I should know about? A lot of times I have to explain that to people. And I'm like, some cultures it's considered rude to look people in the eyes, or some cultures like you can't shake hands. Like those are things that are going to be important for me to know because I don't want to violate that and break down that rapport. So, when possible, connect clients to culturally responsive resources, therapists that share their language, support groups that are relevant to what they have going on, programs that respect spiritual traditions. And then demonstrating that respect on all sides helps build that identity and trust, and then encourage sustained engagement and treatment as well. One of the most practical ways that we can support clients is by connecting them to local resources to address basic needs. So I talked about this briefly, like transportation, so bus vouchers, rideshare assistance, community volunteer driver programs, MTM transport, housing and shelters, so local housing authorities, transitional living programs, emergency shelters, like places like St. Vincent de Paul. There's some that will pay like 1 month's utility to help somebody get on their feet. So a lot of those are going to be beneficial. Employment and education, workplace development, GED program, community colleges, voc rehab, all of those. Peer support and recovery. So with peer support, adult peer support was cut by Medicaid last year, so recovery coaching is still reimbursable and exists. But having them go to, like, they could go to community meetings like AA or NA or Dharma Recovery, Celebrate Recovery, recovery community centers, peer mentoring programs, those are all beneficial as well. And then any kind of family support that they might need, parenting classes, childcare assistance, family counseling is always helpful. You can keep a up-to-date list of local contacts and referral numbers. Offering these resources communicates that you care about the whole person, again, not just the compliance. And it helps remove obstacles that might otherwise derail their treatment and probation success. If you are struggling and you're like, hey, I need a resource for this individual and I don't know what is available, you are always welcome to reach out to me. I have a pretty incredible case management team, and somehow they know every resource that's available for everything. I don't know half of the ones that they do. So if you need a resource for something, I'm sure they've got it. And then success. It's not just about the absence of violations, it's evidence of growth. Look for indicators like consistent treatment attendance, improved employment or housing stability, positive feedback from the provider and the client. Again, we want to celebrate those small milestones, a month of sobriety, completion of a module, improve punctuality, document these wins, and then when appropriate, share them with the court and treatment team. Your progress shows the work that you're doing in treatment, and here on probation is paying off. So let them know that to keep going. And then for you guys, know that you are also creating like a safer, healthier future. Thank you. I feel like I'm like right on time too.
Yeah, you're good. Does
Yeah.
anybody
Time for
have
questions.
any questions for Amy? I think I like that you mentioned the reinforcement of stuff, Amy, because I think that's an evidence-based supervision practice as well as that 4-to-1 or 5-to-1 rewards
Hmm.
to sanctions, and
Yeah.
it's shown to change behavior. So I think I love that you said that. Um, Anything else for Amy before we let her go with our thanks?
I have a question about drug testing. And I
Yes.
know with some of the cuts that have been happening and virtual treatment,
Yeah.
I've noticed a lot of providers not doing testing or making that effort. Is that a new trend? And what's going on with that?
So That's a good question, Amanda, and you're not gonna love my answer because it's I don't know. I haven't seen anything about drug testing getting cut. I know with telehealth that like those in rural communities it is somewhat limited, but I also know that some drug testing companies, like the one that I use, they can do like send out mouth swabs and then watch the person do a mouth swab and send it in. There are ways to mitigate it. I don't know what other agencies are doing. I would encourage you to ask them and be like, "Hey, what's up with drug testing? Like, why are you not doing it?" I do think it's an important part of treatment and having that additional level of accountability.
Amanda, do you have a provider up there or do you send people to Boise?
I send people mostly to Boise, but also across the state. And
Hmm.
there's been a couple providers that don't have a great answer as to why they're not pushing the testing.
Yeah, and I would just ask, like, maybe push and ask about like do they have options for like some sort of mail-in test. um some of those rural areas do get a little difficult just because
Yeah,
there's not always a drug testing place nearby.
that's what I was going to say. We have some sort of deserts around the state. I know it's a problem for treatment courts too, but yeah, I don't know either how common or uncommon it is for providers to just do their own instant tests, the iCup or whatever. I don't know how often that happens or doesn't happen, or why a provider would opt not to do that if they don't have other options. But
Yeah,
good question.
I brought in-house testing to try to make it easier for me, so I don't know what other providers are doing. But if
Cool.
you have some that need to collaborate or need ideas, you can always give them my information, and I'm happy to help them navigate.
I don't see anything in the chat, no other people coming off mute, so I'm going to assume we are good to go. Thank you, Amy, for doing
Thanks.
this for us,
Yeah.
and especially thank you for doing it for free because that's in our price range. Um, and I just want to remind
My
everyone
time is worthless.
no. Um, Priceless is different.
There
Priceless.
you go.
Um, I also want to remind everybody again, send me your post rosters. Please fill them out completely and legibly and send them as soon as you can. I usually wait about a week to make sure I have everybody, and then I try not to send stragglers over to Ada County for them to add on. Um, and as always, if you have any suggestions about topics you'd like to see us cover in future quarterly trainings, please, please, please reach out to me, reach out to Carrie, anybody on the training council, and we will try and track something down. So, again, thank you all for being here. Thank you, Amy, and we'll see you all next time.